And the topic of discussion is hearing assessment in infants, children, and adolescents. And these are the recommendations beyond neonatal screening. And the presenter is Dr. Julia Hecht. Her sign name is this, and she is from New York. She practiced medicine in New Mexico, Albuquerque. After her studies, she moved to New Mexico, where she practiced becoming a pediatrician. Also, she is within the community of a community pediatrician, and she has focused on her work on pediatric care. And she's a close friend and very interested in pursuing and furthering the advancement of pediatrics. Hello, Julia. The floor is all yours. Welcome.
Thank you for that introduction, Julie. It's really my honor to be invited to share about this policy in the deaf community. Oh, we're waiting for interpreter. And to be presenting at a school for the deaf, I'm really honored. So hi, everybody, and welcome. I'm glad to see so many people interested in AAP policy, which we're going to talk about today. And first, I want to add a little bit more about my background. As you heard, I'm located in Albuquerque, New Mexico, and I'm retired from clinical practice. I don't take care of patients anymore, but I was a community pediatrician in Albuquerque, and I set up a deaf access program to serve deaf and hard of hearing children and children whose parents are deaf. I also used to work as the medical director and school doctor at NMSD in Santa Fe. From 1998 to 2009, I was the school doctor there. And I had the unique experience for a pediatrician of serving under two deaf superintendents. I've been learning ASL since 1983, and I had the privilege to spend 2 summers and a semester of college at Gallaudet when I was an undergraduate. And that has served as the foundation for my ASL and my introduction into the deaf community. I've been involved in EHDI, EHDI, or Early Hearing Detection and Intervention, for many years at the state level with the New Mexico Department of Health, and at the national level with my professional organization, the American Academy of Pediatrics, or the AAP for short. I had the opportunity and privilege to be an author of a policy report called a clinical report by the AAP, and I've been invited to talk to you today about this report. I want to be clear that I'm not representing the AAP today. I'm here as an individual, and if you have any concerns or comments about this talk, then please contact me and not the AAP. So here's the title page of the report. It's called Hearing Assessment in Infants, Children, and Adolescents, Recommendations Beyond Neonatal Screening. And this means that the report did not actually focus on EHDI or newborn screening. It's about assessing hearing and identifying children who are not born deaf or hard of hearing, but become deaf or hard of hearing sometime in infancy or adolescence. So my objectives for you today are that you'll become familiar with what the AAP is and how the AAP policy is determined, that you'll become familiar with the 7 recommendations of this particular policy, and that you'll understand how the AAP's partnership with deaf leadership led to a more informed and equitable policy. So this is what we're going to cover in today's discussion. I've already been introduced, and I'm going to share a little bit about the organization that created the policy and a little bit about the process of policymaking. And I'll tell you about some of the equity and inclusion steps that happened that impacted the policy that involved deaf participation. I'll talk about the AAP's Words Matter campaign and the actual changes to terminology in the policy. And we'll go over the 7 recommendations, and then we'll focus on recommendation 7, which includes guidance to primary care pediatricians on caring for deaf and hard of hearing children in their practice. And I'll be taking some breaks for questions and comments at the end. Yeah, so we're going to hold questions till the end of the talk. So the AAP's mission statement is to attain optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. And to accomplish this, the AAP shall support the professional needs of its members. It has a membership of 67,000 pediatricians. And that's why the policy is so important, because it reaches a very broad membership of practicing pediatricians. Most of them are primary care pediatricians. To be a fellow, which is the highest level of membership, you have to have graduated from medical school, trained to be either a pediatrician or a pediatric surgeon, and then completed this training, which we call residency, because you practically live at the hospital for several years. And then you have to pass the specialty board exam. The AAP was founded in 1930 by a small group of pediatricians to advance the new idea that children have unique health and developmental needs, and that because children until that point were really thought of as mini adults. Looking at public documents about the AAP from 2021, we see that it has 530 employees, but 11,600 volunteers. And so I'm considered one of those volunteers. We actually pay dues, and then we work for free, writing policy, creating conferences and educational activities and advocacy with support from the paid staff at the AAP. And the reason that we do this is because we support the mission of the AAP. The AAP creates and publishes over 500 books, brochures, and pamphlets for parents and pediatricians and other professionals caring for children. And it publishes the premier pediatric journal called Pediatrics. It has a circulation of about 68,000, and it's in this journal that all AAP policy statements are published. Generally, policy statements are thought of as state-of-the-art guidelines and recommendations for best practice, with explanations of rationale and citations of the scientific evidence supporting the recommendations. Policy recommendations have been used in litigation, meaning lawsuits, to hold physicians accountable for their practice. So there's a lot of care about the language used when creating policy. And there's actually a committee that reviews all policy for potential legal pitfalls. And it helps us strike a balance between stating best practice based on the evidence, but also allowing for some degree of freedom in how individual pediatricians practice. Policy development at the AAP is a long, slow process that takes several years and involves many steps. Policy is developed by a group of experts from within the AAP membership based on scientific evidence and consensus or agreement among the authors who share in the responsibilities of finding the evidence, writing the policy, and responding to feedback from reviewers. Generally, relevant committees at the AAP offer members with particular expertise the opportunity to write policy. There's no payment involved, it's purely volunteer service. And the authoring group will develop the intent or the purpose of the document, which is in itself an 11-step process. We create a detailed outline about what we think should be covered, and then this gets submitted to a policy committee of the board of directors for their approval. Once it meets approval, the research and the writing begins, which takes a few years. When a first draft is ready, it goes through another 11 steps. And part of this process is review by AAP internal reviewers and also external reviewers. And then the draft undergoes revision based on the reviewers' comments. Finally, when the final draft is ready, it goes to executive board review and review from the board of directors. Then another revision process happens based on their comments and back for final approval. So by the time the policy is published in the AAP's journal Pediatrics, it represents the AAP and the AAP stands behind it. It isn't considered the work of just the authors listed. This policy that I'll be talking about today did not go through the intent process because it's actually an update to older policy from 2009. I was one of the internal reviewers and I had extensive comments and suggestions. So the authoring group invited me to join the team and help them complete the policy. And from the time I joined, I believe it took us another 2 years until publication. What I was able to bring to this work, in addition to my clinical experience and my interactions with the deaf community, was my experience working with deaf leaders on an AAP committee. In 2018, the AAP received a 5-year grant that led to reorganization of the EDI program. And part of this was the creation of an advisory committee that had about 12 members. These included audiologists, parents of deaf children, state EDI coordinators, and others involved in newborn hearing screening and early intervention. It also included 3 pediatricians, and I was one of those. And it also included 3 deaf leaders, a lawyer, a psychologist, and a parent advocate and family services expert. Having these 3 leaders of the deaf community allowed the committee to better understand deaf perspectives on AAP EDI issues. One of the topics that was addressed was the impact of deficit framing and medically acceptable terminology that could be considered demeaning to deaf people. Terms such as failed, lost, or impaired. These conversations made a big impression on me, and I was able to take this knowledge with me to the writing of the clinical report. So you can see how the AAP's decision to include the deaf committee in the EDI program made its way into other AAP policy. It's one thing to be aware of deaf perspective and try to advance them. It's another thing to have people ready to hear and accept these suggestions. Fortunately, during this time, the same time period, the AAP began their Words Matter campaign and published a document outlining principles of AAP guidance on inclusive anti-biased language. I've included the webpage link at the bottom of this slide, and it's really a beautiful document. If you're interested, you should look it up and read the whole thing. Here's a small portion of it, and what the slide says is, inclusive anti-biased language honors the rights of groups and individuals to define their own identities. Language has the power to change minds, hearts, behaviors, and relationships, and to create narratives that shape our perceptions and beliefs. Thus, it is important to carefully consider language when developing AAP content to convey messages and propose solutions that promote diversity, foster inclusion, and advance equity. Language should recognize the inherent value in each individual and mitigate the harm perpetrated upon communities that have been marginalized and socially, politically, and economically disadvantaged. So this campaign really created the atmosphere required to be able to advance more equitable and respectful language in the document. So turning to the current report, as I mentioned, it's an update to a previous report from 2009. The changes to the new report include updated terminology, which I just mentioned, alignment with new policy. Our advisory group had already created a document called a tip sheet for providers about newborn hearing screening and intervention that for the first time, we were able to include American Sign Language in that sheet. And so that groundwork was already done. And so when we aligned this other new policy that we were writing with the tip sheet, we could include ASL without having to fight for it because we already had that fight. And we had established the presence of ASL in an AAP publication. There's a part on risk assessment, which I will explain shortly, and that was updated based on the latest research. And there is guidance for primary care pediatricians in caring for deaf and hard of hearing children in their practice. In this guidance, we included discussion of language acquisition and language deprivation, ASL and bilingualism, cochlear implants and hearing aids laws, and advocacy and deaf culture and deaf families. So at the outset of the report, there is a section called terminology. And what we say is the following. Readers may note the removal of deficit framing terminology, such as loss, failed, impairment, etc., to reflect that children who are deaf or hard of hearing are equal, healthy, and whole. The use of non-pathological terminology does not signify a change in the need for expeditious identification and care for children who are deaf and hard of hearing to reach their optimal potential. So the first recommendation states all children should undergo a risk assessment for changes in hearing thresholds by utilizing objective and evidence-based risk factors for delayed onset hearing changes. So what does this actually mean? And what is meant by risk assessment? It means that a pediatrician who is seeing a child should determine at every visit whether this child has a higher than typical likelihood of becoming deaf or hard of hearing. And if so, they should do something about it. And that's really what this report focuses on. We know that for every 1,000 children, approximately 6 are deaf or hard of hearing. Half are born deaf or hard of hearing, and the other half become deaf or hard of hearing sometime in childhood. Currently, AAP policy about preventative health care recommends newborn hearing screening, which will happen in the hospital when the infant is born, or shortly after if they're born at home or outside of a hospital. And then hearing screening at age 4 years of age. So what happens during those first 4 years when we all know those years are so important for language acquisition? So this policy discusses how the pediatrician should assess their patient for the risk of becoming deaf or hard of hearing and what to actually do about it. And how do we assess? Well, we look at family history. Is anyone in the family deaf or hard of hearing? And we're especially interested in whether anyone was born deaf or hard of hearing or became deaf or hard of hearing during childhood. We look at the birth history. Did the infant spend time in the NICU? Did they have certain infections at birth? There's a long list of different factors related to birth history that increase the chance that a child may become deaf or hard of hearing. Even though the child may screen to be hearing at birth, events around the birth history can impact their hearing years down the line. Medical history. So we're interested in whether the child is having a lot of ear infections. Have they had meningitis or head trauma? Certain head trauma can cause changes in hearing. Then there's a physical exam. The doctor will do an exam and note features that are associated with being deaf, such as different colored eyes, having a white forelock in the hair, or the way the ears have formed. And finally, they'll assess spoken language milestones, which are usually reported by the family. So recommendation number 2, children at all ages should have prompt objective hearing screening if there is either clinical concern or caregiver concern of permanent or ongoing hearing change. So in addition to risk assessment, any concern by a parent or caregiver or the physician about the patient at any age should prompt further investigation. Many parents have experienced being told not to worry by a physician, only to have a hearing change identified months later. And this should never happen. Family members may report inattention, that the child doesn't respond to sounds as expected, or there is a speech delay. The physician should check the ears for infection or fluid behind the eardrum to make sure that that's not causing a temporary situation. Then, if the office has the ability to actually do hearing screening in the office, they should do that. And if not, they can refer to audiology. If there is infection or fluid, then the child's ears should be rechecked at a later date and have their hearing screened at that time. Recommendation number 3, a child with a positive screen for atypical hearing thresholds in one or both ears should be referred to an audiologist for diagnostic consultation and testing. This means if the office hearing screen shows the child may be deaf or hard of hearing, then they should be referred to an audiologist for a full evaluation. The report also states that screens are not perfect and they may give a false negative result. So if the screen shows the hearing is typical, for example, the child is hearing, but the family still has concerns over the next few weeks, then that child should be referred directly to audiology.
Actually, can we have one moment to switch over to the next interpreter? We're currently going to be changing over to the next interpreter. Yes, we can see you that way. I can't see the slides. All right, can everyone see me? All right, perfect. Thank you. Oh,
Okay, so recommendation number 4. Behavioral audiometry may be impossible or inaccurate for some children with developmental or behavioral health conditions. In this situation, referral to audiology for electrophysiological hearing testing using ABR with sedation may be more appropriate. And basically what this means is that not all children, even at later ages, will have the ability to follow directions. They may have conditions that make it difficult to interpret the results. So in those cases, they may go to audiology rather than having screening in the office. And they can have testing under sedation that looks at the brain's response to sound. Recommendation number 5, newborn and childhood hearing screening results should be reviewed with families and documented to facilitate tracking and follow-up. Contact state EDI program in accord with reporting requirements. I think that's pretty clear and obvious. Recommendation number 6, to prevent false negative results and to avoid delays in identification, access to language and support screening tests should not be repeated more than once before referral to audiology for consultation and further testing. Basically, what this means is that a child should not be tested repeatedly to try to get a desired result, because that will delay care. One retest is permitted, but not numerous. Okay, so we blasted through those first 6 recommendations pretty quickly, and I'm gonna spend the remainder of my time talking about recommendation number 7. So there's a lot of content in the body of the report, the policy report, about recommendation number 7. And we'll just go through it item by item. So recommendation number 7 says, if comprehensive audiologic evaluation identified the child as deaf or hard of hearing, discuss the importance of supporting the child's communication, language development, and socio-emotional needs within the family and school settings. Refer for early intervention specialized for children who are deaf or hard of hearing. Other medical specialty referrals may also be appropriate, and these include audiology, ENT, which is otolaryngology, it says on the slide, that's the ENT, speech pathology, ophthalmology, which is the eyes, genetics, and a developmental specialist, etc. So that's basically letting the primary care doctor know that they may need to refer to all these different specialists. And that's usually the responsibility of the primary physician, so the primary pediatrician. Okay, so now we're going to talk about the role of the primary care pediatrician in caring for children who are deaf and hard of hearing. That's included in the policy under recommendation 7. So it states that pediatric primary care physicians, or PCPs, should be familiar with the most common issues affecting children who are deaf or hard of hearing to provide optimal care and support families. And it may come as no surprise to the parents who are attending this talk that most pediatricians have not been provided adequate information in medical school and in our training about caring for children who are deaf and hard of hearing. So we go into some depth in this policy report about what that means. The role of the PCP is to provide caregivers with appropriate information and opportunities so they can make informed decisions. And we state specifically that this discussions should be evidence-based, meaning it should come from scientific studies about what is best for children and not necessarily an assumption by the pediatrician based on, let's call it, common knowledge. These should be based on what's the evidence in the literature, and refer to appropriate resources and specialists. Families need respect and support. The report states that families who are deaf or hard of hearing have knowledge and experience that will influence their decisions. Hearing families who are unfamiliar with deaf people are beginning a journey in learning about raising a deaf or hard of hearing child. PCP should encourage the expression of family desires. And they should ensure that families are receiving appropriate services for their child under the law. This includes IDEA Part C and then B, or a 504 plan. Infants and young children should receive early intervention that is specifically for children who are deaf and hard of hearing. So language deprivation. The policy is the first document from the AAP to mention language deprivation. It states, the primary concern for a child who is newly identified as deaf or hard of hearing is access to language. Because the neurocritical period for language acquisition is birth to 5 years, children who become deaf or hard of hearing under the age of 5 years are at risk for language deprivation. Practitioners should understand that language deprivation begins in infancy and can continue during early childhood if a child does not receive fully accessible language input that is rich and immersive to stimulate typical brain development. Language deprivation results in language disfluency and decreased literacy, and it impacts higher cognitive function. Sequential memory, understanding cause and effect, mood regulation, and other features of abstract thought and executive function are affected. Ensuring full access to language, such as the family's spoken language, if possible, and or a visual language, can prevent language deprivation and its permanent negative consequences. It is common for hearing families to desire that their child learns to communicate in spoken language. And the policy describes cochlear implants and hearing aids. It talks about the FDA's authorization for them, but it does talk about them as tools for audition, and explains that children with cochlear implants do not spontaneously learn spoken language. Generally, there may be rare cases, but in general, children with cochlear implants must have intensive therapy to learn spoken language. And it also states, and this is very important for pediatricians, that to know that cochlear implants and hearing aids may not prevent language deprivation. And we put this in here because it's very common for pediatricians to refer the child to ENT, and when they get cochlear implants, to think that everything's going to be fine, they got their implant. And we're very specific in this policy report to talk about what is required from pediatricians to monitor children's language development. American Sign Language. The policy introduces the topic of ASL as a natural visual language of the deaf that may provide immediate communication and bonding in the home. ASL has been shown to support spoken language development and may prevent language deprivation. The policy specifically states that the need to choose ASL or spoken language is a false dichotomy. And it states that long-standing bias against ASL contributes to language deprivation. Bilingualism. The policy states, the policy cites a study that reviews the health benefits of signed and spoken language bilingualism. And as I mentioned, it's very specific in its message to pediatricians that families do not need to choose between modalities, signed or spoken. Language development of deaf and hard of hearing children should be monitored by pediatricians just as we monitor language development of hearing children. And for deaf children, we should also focus on the children meeting their language milestones and consider that those aren't meeting language milestones are falling behind. And those that continue to be late in achieving their language milestones and those who are falling behind are at risk for language deprivation, and this needs attention. The policy also provides a link to ASL developmental milestones so that the pediatrician can have the same discussions with families who are using sign language with their deaf child as they do with their patients who are learning spoken language, such as hearing patients. The school-age child. The policy discusses school-age children who experience a change in hearing and explain that these children have rights under the law, either under IDEA Part B, or if they don't meet the qualification for Part B, they should have a 504 plan. Some states have enacted their own Deaf Child's Bill of Rights, and providers should consider such resources as state commissions for the deaf, their state EDI program, and parent advocacy groups as sources for them to learn and also to refer families. I see we're kind of running short on time, and I'm okay, wait a second. We're going to talk about deaf families, culture, and lived experience. And then I will briefly talk about the medical piece, the specialty referrals, so that we'll have time for questions. The policy has a paragraph titled Deaf Families, Culture, and Lived Experience, and it states that culture and personal experiences will likely influence the degree of medical intervention that family members desire for their deaf child. Parents or caregivers who are also deaf or hard of hearing may consider themselves culturally deaf and value ASL. They may have a different perspective than caregivers for deaf and hard of hearing children who are themselves hearing. Culturally deaf families will have had their own experiences with hearing care specialists and special education system and hearing technologies. Basically, that was included to set pediatricians up to respect deaf perspectives, because often they'll just come with their medical perspective and not appreciate that there are the wisdom of the deaf perspective. Basically, they may not be aware of that, so we included that. Many deaf and hard of hearing adults do not identify as culturally deaf. However, they will also be informed by lived experience. Many deaf and hard of hearing people report negative or traumatic experiences with the healthcare system, and developing a rapport of trust and respect for their lived experiences, expertise, and cultural perspective is essential for providing a medical home for children from families that are deaf and hard of hearing. The Americans with Disabilities Act requires that interpreters be provided for caregivers and patients who prefer to communicate with medical personnel in ASL and should be arranged in advance. So I think to give some time for questions, I'm just going to show you this slide and basically let you know that this refers to those specialists that I mentioned when I was reading the recommendation. And then finally, there's a summary, and this basically reviews all that we talked about today. And so I'm just going to stop here and let's open up for questions or comments. I think Julie was going to lead the question and comments. And okay, here she is. Thank you.
Patty, you're muted. I currently cannot unmute.
Yeah.
Oh,
All right. So Julia, yes, thank you. Your presentation was amazing, thinking about all the work that you have done. And I know what you have is not an easy job because of the system, what a challenge it is. And they're small changes, but they're still happening. We've seen some progress and the recommendations you've made to improve that progress. And of course, your opening statement, the emphasis on deaf families, their lived experiences. Emphasis there is so important, and I'm so glad you talked about that. And the resources that folks use is just not always enough. And so you talked about deaf mentorship, deaf coaches, but what about all these other resources that deaf families have as support in that new infant screening system, for example? And thank you. I'll turn it now over to the folks who are watching the presentation and see if there's any questions that you have for Julia. If you could type your questions into Q&A at the bottom. Okay, if people would like to type their questions, Julie will be repeating them in sign language. There is a question. Because you've made so many recommendations, which recommendation do you think is the most important or the one to focus on primarily?
Well, that's a hard question. I mean, obviously, we gave a lot of context to recommendation number 7. But recommendation number 7 is what to do when a child has been identified as deaf or hard of hearing. And the first 6 are about how to make sure we do identify those children. And if we're not identifying children, then they're not getting the services and they're not getting language. And so I can't really say that number 7 is the most important because we need to identify kids. That's really the first step. And we broke it down into 6 different parts. But as you can see, we think the care of children who are deaf and hard of hearing really needs a lot of attention. And I really hope that this policy gets put to good use in clinical settings because children and families deserve it.
Oh, thank you. And another question. For training the pediatricians, how can we convince the medical school institutions about the infant hearing tests and include the language milestones 0 to 5 as part of their practice when they get to be physicians, because it's not all about the ear. You know, we were talking about language development, and you reinforce that, especially in the critical period 0 to 5, so that then the children have the language to be kindergarten ready.
That is so true, and it's a very good point. Well, I've spent my career thinking about this and trying to work on improving this. And I think if we consider the clinical report as a first step, I think it's an important pivot where we really shifted the focus to language rather than speech. And we shifted the focus away from comparing deaf children to hearing children and talked about children reaching their maximum, their optimal potential and their maximum potential as goals. I think that's a really good first step, and it'll be really interesting to see what we can do with this. And when I say we, I'm including the deaf community and all those who are involved in service delivery for families, because this is a really important document because, as I mentioned, the AAP really creates state-of-the-art recommendations for a very large number of pediatricians, but they're not all going to be sitting and reading this intensely. We need to use this by creating campaigns where we educate pediatricians, we continue to educate. And I have some ideas for doing that within the AAP, but I think that everyone, across America who works in service delivery for the care of deaf and hard of hearing children and parents should use this policy as a tool and a jumping off point. And see what you can come up with, because I'm sure you have very creative ways of educating at local levels. You know your communities and you know who the pediatricians are. Let's see what we can all do together from this point.
Oh, totally agree. And now I have a question. Thank you. What are the next steps in that series of steps that deaf professionals can do to create that kind of partnership? Because, sometimes we experience some resistance because of folks not understanding that deaf people really have a large role in the EDHI system. So what are the next steps to partner up and start making progress so that we have a large part of these early phases with the newborn infant screenings? And the earlier the parents want them, the more exposure they'll get. And they have had studies. I think they just had 2 recent studies that are not published yet, but both of these studies have interviewed families of deaf infants and young deaf children, and all of them wish that they knew that they could go back in time before the baby was born. If they could, what would they have done differently? And I think about 80 or maybe 85 to 95% of all these families wished they had met a deaf adult before the baby was born. Oh, that message is so amazing and powerful, and unfortunately so true. How many have we faced system barriers that we can't get through with this partnership? We were talking about advice to them. What would you give a specific advice to those resisting partners?
It's so tough. And I personally, it's always been bewildering to me because I always choose to be with deaf people, and I don't understand why pediatricians wouldn't be consulting with deaf people. Clearly, they have answers, and they've worked out these solutions over their lives and over generations. And there's just such a lot of wisdom that is sheltered in the deaf community. And I know the deaf community wants to share it. I mean, I've seen it, I've witnessed it. And the one thing that comes to mind is I'm on a HRSA advisory panel for Eddie, and the Colorado, there are individuals from Colorado on this panel as well. And they talk about their model in which every family that has a child who's identified meets with a deaf adult and who is trained in sort of welcoming this family on their journey. And I was really happy to see that Colorado, that HRSA was holding this up as a model program. Like kind of like, oh, let's look up to Colorado. They're doing something amazing. And I thought to myself, yeah, this is great. Let's do this. And this is, I think we need to talk with HRSA about a campaign, showcasing this model so that it becomes the norm in every state.
Oh, thank you. Oh, I'm so excited about that. And so with HRSA, I know that they're changing their requirements for EDHI. I think at the last deaf coaches mentoring services, they added other language about the milestones and part of HRSA and part of the requirements. And so I'm hoping then the next edition would be working with deaf families. So they've already amended, and so they have other ones. They need to talk to those people who have the lived experience. So thank you. Thank you. Any final words that you would like to give to us before we close our webinar today?
I think it's a huge step. I don't know if you all can feel what a big step this is, but I know the medical world and I know the resistance. I've experienced the resistance my whole career. This is a huge step, this report. And my final words are that we should, I want to reiterate what I said earlier, which is like, the work is not done. The work is beginning a new phase, and we should, roll up our sleeves and like do something with this. And don't let it just like gather dust on somebody's shelf. We should keep talking about how the AAP has said this is important. This is important. Because honestly, there are forces that would like to see it retracted, and it's not going to be retracted, but there's outspoken resistance to it. And there are going to be other policies coming from the AAP, and it's possible that those policies there will be a backlash through those policies. So what I think is we have the opportunity now to make the most of this so that it has to be impossible to go backwards. We have to make it impossible to go backwards.
I want to thank you for your allyship in terms of a policy level. And in other words, I like to use co-conspirators, I should say. That's what we are. And so thank you for your work. And you always include deaf people in your work, that you work side by side. It's not like a single decision maker on these policies. And you represent what policy making and developing good policy looks like. Working with deaf people, getting them involved as leaders. And I want to thank you. You are such a great model to the rest of us. And thank you for your presentation. We'd like to invite you back again, if you're willing. Thank you. Now, have a wonderful Friday evening, everyone. Thank you for joining the webinar. They are recording this, and it will be edited, and then we'll distribute that, and you'll see it at CSD's website. All right. Thank you so much, and all have a good weekend, everyone.